Hi, good day to everyone. Hope everyone is fine. Welcome to Ifso Journal Club webinar. My name is Aomie Wu. I'm an upper GI and bariatric surgeon from Singapore. I'm also a member of the Ifso Communication Committee. The title of the article chosen by Ifso for discussion today is Revisionist Surgery or Pharmacotherapy for Insufficient Weight Loss and Weight Regain After Primary Bariatric Procedure, a Discrete Study. So before starting the presentations, just a few announcements and then a reminder that this webinar will be recorded and that it will be available to review again after the recording either on the Ifso YouTube channel or Ifso Academy in the website. So please feel free to share with your colleagues or whoever missed the webinar, or you can also review if you didn't manage to attend fully for today's webinar. And without further ado, I would like to introduce the senior author of this article, who is a friend of mine and also colleague of mine. We work together in Singapore, Dr. Lim Chi Hong, to present his recently published article. Dr. Lim is a senior consultant surgeon from Department of Upper Gastrointestinal and Bariatric Surgery, Division of Surgery, Singapore General Hospital. So before Dr. Lim starts his presentations, I would like to ask the organizing committee to share the poll so that we can have some review of the poll. So there will be a two quick poll. So we'll wait for a few seconds for the participants to answer. And then please share the results after the. Okay, this is what the participant has voted. So preferred choice for the case of the insufficient weight loss after the primary surgery, 42% revisionist surgery, 50% pharmacotherapy. Let's move to the second one. The second one would be do you think that insufficient weight loss and weight regain, are they the same? We will wait for a few seconds again for the participants to vote. Yeah, so the 96% thing is not the same. Only 4% thing is they are the same between the insufficient weight loss and weight regain. Okay, without further ado, I think Chiao, please share your presentation. Thank you.
Thank you, Ong, and I would like to welcome everyone for the Journal Club today. Currently, it's actually 8 p.m. in Singapore, so good evening for all the colleagues in Singapore. And I think in Europe, it's probably around 2 p.m., so good afternoon. So as Ong mentioned, the paper that I'm going to present today is a revisionist surgery or pharmacotherapy for patients who have insufficient weight loss or weight regain after the primary bariatric procedure. These are my disclosure. Bariatric surgery is currently the most effective and doable intervention for severe obesity, and I think that everyone would have agreed with me. But weight regain is actually a common problem, and it's important, but it's actually not very well studied. And I think weight regain is also depends on the surgeon's experience. I think more procedure or more bariatric procedure they perform, they more likely will see weight regain or insufficient weight loss in their practice. And there was a paper by Benjamin Clapp, was published about 3 years ago, looking at the long-term. It's a meta-analysis looking at the long-term follow-up for patients after the sleeve gastrectomy. And you can see that the weight regains prevalence was staggering, is about 30%. And again, I'm sure everyone is familiar with this graph. It's just a graph that I get from a Swedish obese subject study. And again, if you see it, regardless what procedure you perform, it's always a risk of a weight regain. Although we don't do band and VBG anymore, but even with the Roux and White gastric bypass, as you can see, after 5 years, there was a significant weight regain. And as I mentioned, the phenomenon of the weight regain is actually poorly understood, and I think that it remains kind of the major knowledge gap when it comes to these problems. And this is actually a paper published last year by Ansari. It's actually a systemic review looking at these two problems, so weight regain and insufficient weight loss. And then what Ansari tried to do is that he tried to put up all the categories, different categories of knowledge gaps, and then he kind of used a cross to signify the degree of the knowledge gap. So basically, if you have more cross, means that it is a larger knowledge gap. As you can see that we actually did quite poorly when it comes to insufficient weight loss, and you can see that they almost all max up at 4 cross. Even with the weight regains, we also still have quite a significant knowledge gap. And I think that mainly the two reasons why this problem is poorly studied. I think one is that we actually don't have a very good or standardized definitions when it comes to define weight regain. This is an example. You can see that different study using different definitions. Some use a percentage of excess weight loss, some use percentage of total weight loss, some use BMI, and some even use the actual the weight in kilogram. And of course, in insufficient weight loss, the data is even more limited. And the second reason why this problem is poorly studied is because of to able to study weight regain, you do require a long-term follow-up, because most of the weight regain happens 3, 4, 5 years later. And this is also the cohort of patients who tend not to come back to see you, whether it's because they feel that the weight regain is kind of disappointing and they feel embarrassed to come and see the primary surgeons, or because they think that you kind of fear them because you perform the surgery and then they don't have a long-term result. So as I mentioned, we actually have a very limited data, especially on patients who have insufficient weight loss. And I think more importantly, even though there is a study looking at these problems, they tend to group them together and they report the result collectively. I think the reason for that is because, as I mentioned, usually the numbers sample size is quite small. So to make it into statistically significant, they do require to kind of marry them together. But I think this probably is not a good idea, because I think that insufficient weight loss and weight regain, I think a lot of you guys will have agreed with me based on the poll that we think that, I mean, we agree that these problems have a very different biologies, and I believe they also will respond very differently to different kind of therapy. And this, again, this is a paper that from my center was published last year. As you can see, just to show you two things. Number one is that, as you can see, each dot represents a patient. You can see that the response is very heterogeneous. Number two is that the maximum weight loss tend to happen between 12 to 18 months. And that is where I think when it comes to definitions is where we define the nadir weight. And currently the best or the available treatment for these two problems, you start with behavioral therapy. If that fails, most people will move on to pharmacotherapy and finally for revisionist surgery. And this is a list of medication use for patients who have insufficient weight loss or weight regain after bariatric surgery. And and the list is growing. You know, as you can see that this is a paper published 2 years ago. We have liraglutide, semaglutide, but most of the study looking at pharmacotherapy for weight regains are using old drugs, mostly phentermines and also using a topiramate. And this is one of the meta-analysis looking at the use of medication after bariatric surgery. And just to point out, if you pay attention, most of the good response, if the paper show that there's a good response, tend to have a short follow-up. If you look at those who have a follow-up 12 to 24 months, the result actually is quite disappointing. As you can see that the effect is actually diminishing. For example, if you look at the paper from the Gogojo, and you can see that the percentage of weight loss after surgery is only about 3.2. If you look at the Hanipa, it's even more disappointing. It's for sleeve, it's only 0.3%. The next options that we have is actually revisionist surgery. And if you look at this table from the ASMBS, the revisionist surgery is actually one of the fastest growing category of the bariatric surgery in the United States. You can see that from 2013 to 2019, it actually increased it from 6% to about 17%. And when we're looking at the surgery, revision surgery for failure of weight loss, this is one of the systemic review and the meta-analysis were published early this year. And again, just I pointed out earlier on, most of the study, either they don't have a very clear definitions for insufficient weight loss or weight regain. Even if they have a clear definitions, they tend to report the outcome, they lump it together and report collectively. And again, I think that may not be a good idea. So the objective of my study is actually quite simple. We just try to define these two problems, weight regain versus insufficient weight loss, and then we observe their response to pharmacotherapy and also for revisionist surgery. So it's a retrospective study. We look at all our database, bariatric database called RECAP, of those patients who actually underwent revision surgery or those who have started on pharmacotherapy after primary bariatric procedure. The study duration is from September 2008 to December 2018. I think it's important to take notes that we only include conversion surgery. It means that we convert an index procedure to a different type of procedure. So for example, if the patient have a sleeve and have weight regain and we re-sleeve, this patient is not going to be included because this is known as a corrective surgery. And also for those patients have worldwide gastric bypass, they have a dilated pouch, or they have a widening of the anastomosis that require endoscopic pouch reductions or tightening of the GJ anastomosis, this also will be excluded. And as I mentioned from the previously, is that the maximum weight loss that we usually take for this study is between 12 to 18 months. And most of the study also are consistent with our study is that usually the nadir weight happens in this period of time. Okay, so the definition we use to define insufficient weight loss and weight regain, again, is a little bit arbitrary. We don't really have a very good evidence or data to say which one is better. But in this context, we use the insufficient weight loss as a percentage of the total weight loss of less than 20%. And for weight regain is defined as they have a gain about 10% from the nadir weight between 12 to 18 months. And again, we choose these two is based on the study that just published at the BMJ Open. This is actually a Swedish obesity surgery registry. And also, we also refer to the systemic review looking at the definitions of failure of in the revisionist surgery. So I think all the patients who's going for all the revisionist surgery will go through a very thorough nutritional and psychological evaluations. I think this kind of the workup is actually more extensive for revisionist surgery or conversion surgery compared to primary bariatric surgery because the risk of the surgery is a lot higher. And the patient will go through anatomical assessments. For sure, they will go through endoscopy, and depends on the primary surgery. Some will go through a contrast study, some will go through a CT scan. And for pharmacotherapy, we actually documented the time when the medication was started, the durations of the pharmacotherapy, and also the choices of the pharmacotherapy. Keep in mind, as surgeons, I don't usually prescribe all these anti-obesity medications. Those patients I will refer to my colleague endocrinologists, and then they will prescribe based on the patient's medical history or any allergies or reaction, etc. And we also take this opportunity to look at when we think it's better to initiate pharmacotherapy. So because from our database, we found that some patients actually will start on the pharmacotherapy, even they only have partial weight regain, which is defined as they gain less than 10% from the nadir weight, versus those that have gained more than 10%. In terms of conversion surgery, as you can see, mostly we're converting a restrictive kind of procedure, for example, sleeve to RYGB, to band to sleeve, or band to bypass, and VBG to RYGB. We have very standardized follow-up program or protocol. We usually see our patient 2 weeks post-op to look for any potential complication from surgery, and then we see them in 1, 3, 6, 9, 12, 18, and 24 months, and then we see them yearly after. When it comes to statistic analysis, again, it's quite standard. All the categorical variables will be presented as a percentage. And then as for continuous variables, if you have a very normal distributions, and we'll give an as a means and the standard deviations. If the graph is skewed, then we will use a median and the interquartile range. When you look at the differences in the continuous variables, we use ANOVA, and then for categorical, we use a chi-square. When we analyze the multivariate variables, and we use the regressions models. So this is our result, and during the study periods from 2008 and 2018, we identified 599 patients who actually have either weight regain or insufficient weight loss. And we exclude those loss of follow-up. And then most patients, 61% of patients will actually go on to just having a behavioral therapy, whether they will see a dietitians and the physiotherapists and the psychologists. Of then 26%, which is account for about 156 patients, will go for pharmacotherapy. Of this cohort patients, 6 patients end up having surgery because either they having a reactions for side effect from medication or the patient preference, they choose to go for surgery instead. And then so total we'll have about 27 patients who have a conversion surgery. So this is just showing the demographic for patient who went for pharmacotherapy. As you can see, we divide into 3 groups. First one is the patient with insufficient weight loss, and then we have a partial weight regain, and also for weight regain more than 10%. When you're looking at the patient's age, gender, ethnicity, there was no statistic significance. The time when we start from the surgery to we start the pharmacotherapy, as you can see, it kind of makes sense. A patient with insufficient weight loss, you tend to start a bit earlier compared to weight regain. So there's a statistic significant in that. And when it comes to duration of therapy, again, we're seeing that patients who actually have a partial weight regain tend to have a longer durations of a pharmacotherapy, but they all range between 10 to 17 months. As you can see, the percentage total weight loss, it kind of makes sense again. Is a patient with insufficient weight loss tend to lose a bit less. They only lose about 14.9 compared to patients who have weight regains. And when it comes to medications, as I mentioned previously, is that this study, we're looking at the patient from 2008 to 2018. So we're still using mostly old medications like phentermines and the combination of phentermine and the topiramate. So as I mentioned, phentermine is the most common prescribed first-line pharmacotherapy. The second one is actually the combination of phentermine and topiramate. It's really different from North America. I think they have the formula called Xxxiv, but in Singapore, we actually have to prescribe 2 separately. But when you look at the outcome with the pharmacotherapy, it's actually quite interesting to see that the weight loss is actually, although in this table you see there is no statistic significant between the patient who had insufficient weight loss or weight regain, but when we actually combine the 2 group of weight regain, it does show statistic significant, but I kind of questionable is clinical significant because the difference is only about 1.2%. So the result is actually quite disappointing. So as for conversion surgery, as you can see, the demographic, again, patients who have insufficient weight loss tend to have less weight loss. As you can see, the last column, the total percentage of the total weight loss is only about 15% compared to about 33.7% in the weight regain. But other than that, it's pretty similar between the 2 groups. When you actually look at the result, again, it's quite interesting. Although at the pre-revision weight, they're quite similar, it's no statistic significant, but if you look at the percentage of total weight loss after surgery, keep in mind this is only 12 months follow-up. We're looking at 1 year after the surgery. There was a statistic significance in these 2 groups. the patient who have insufficient weight loss actually lose about 24% compared to only about 17% in the patient who have weight regain. So I think obesity is actually a chronic disease, and they have a very high relapsing nature. But I cannot stress more is that when you're dealing with patients who have insufficient weight loss or weight regain, the multidisciplinary assessment is crucial. They need to see all the team member. They have to see the endocrinologists, dietitians, psychologists, and physiotherapists before you actually offer them the surgery. The initiation of the pharmacotherapy is, as I think the poll has shown, that tend to be the first line therapy after they fail the behavioral therapy, because I think the medication tend to be less morbid. As I mentioned just now, is that the pharmacotherapy is slightly more effective in patients who have weight regain compared to insufficient weight loss. But as I said, the difference is actually quite small. The medication used in our study are mostly have been around for a while. They have at least a decade ago. We only have a small amount of patients actually have on liraglutide. But we didn't do any subgroup analysis because the number is just too small and to be meaningful. But as I say, now we actually have quite a bit of new drugs available. For example, we have semaglutide and then tirzepatide, which actually tend to have a very impressive result in the phase 3 trial. And I think will be interesting in the future to look at patient post bariatric surgery and whether they have a better response with these new medications. I think that why the pharmacotherapy in patients who have bariatric surgery less profound compared to primary usage is because I think the mechanism of action is already engaged by the bariatric surgery, because bariatric surgery will have changes the patient gatherings and the GLP-1. So that's why I think with the medications, the effect tend to be suboptimal. But I think it's interesting to see that patients who actually have insufficient weight loss tend to respond better with revision surgery compared to patients who have weight regain. If you actually look at the paper by Benoit, they analyzed over 26,000 patients, and they find that actually bariatric procedure is account for 44.8% of variability in the weight loss surgery. What that means, I think, is that some patients tend to respond better to different bariatric procedure until we have a better way to predict which patient will respond better. I think that the revision surgery has had to be always considered for patients. So of course, there's a limitation in this study. As you can see, as I mentioned, numbers are relatively small. Even for patient, although they, for pharmacotherapy, although they actually showed statistically significant, but as I say, the clinical significance is actually quite small. And also, I think if you look at the conversion types, mostly we convert to RIGB. So there's actually lack of a malabsorptive procedure like the duodenal switch, OAGB, and study. I think that kind of limit our ability to draw very strong conclusions. And of course, for patients, the group that have revision surgery, our follow-up duration is only up to 12 months. And I think it will be interesting to look at whether this difference was sustained for a longer period of time. So the conclusion is that patients who have weight regain after bariatric surgery have a slightly modestly higher weight loss compared with insufficient weight loss when you utilize the pharmacotherapy. Patients with insufficient weight loss tend to lose a bit more compared to patients with weight regain in 12 months after conversion surgery. Of course, the future study will be useful to further elucidate if there's actually these are actually two separate entities, and then whether with a distinctive pathophysiology and then the different response to different treatments. I think that is the end of my presentations. Thank you.
Thanks, Chin Hong. Thanks, Chin Hong, for the presentations. So before we start the Q&A, I would like to remind all the participants to type in the Q&A so that we can address one by Chin Hong. And then probably we can share the polls again, see what after Ching Hong presentations, whether any change in the voting. If I remember correctly, this one was half, I think, previously, before the presentation. Okay, you can show the results if the okay, so still the preferred choice will be pharmacotherapy. Yes. And then yeah, of course, it's a pharmacotherapy as a non-invasive. If can helpful for the patient would be great, rather than the more invasive revisionist surgery. How about the next poll question? So please feel free to type in the Q&A and then we will try to address. Yeah, so it's almost similar. Insufficient is they are not the same. 95% thing not the same. Only a 3% thing that is they may be still the same. Okay. Okay, I think the first question, let me check. Is from the Dr. Jack Simpan said, are your results still valid with the modern drugs? I think you might have addressed earlier, right?
Yeah, as I say, the only modern drugs that we have is actually liraglutide, and as I say, the number just to draw any strong conclusions. Yeah, I think it's definitely something we should study further.
Yeah, thanks, Xiao. So I think before the other question from all the participants, I would like to ask you a few things. So in your study, I think if I remember correctly, if I read the paper, there are 1,400 or 1,500 during the study period, right? So primary bariatric surgeries. Out of them have 500 over got the regain from the flowchart.
Yes.
And then you exclude the 57. And then the 300 over patient has a behavior therapy. So if you minus 500 over patients from the 57 excluded, right? There are others 100 over patients. I'm not sure what happened to those because of the data not.
So as I say, if you add up the pharmacotherapy is around 156 plus the revisions of 27 and then over 300, so they will make up to about 500 and plus the loss of follow-up of 57, they will make up to about 599.
I see. Understand. So the flow chart supposed to be so out of the 599, 57 excluded. So 365 will goes to the behavior therapy, right?
Yeah,
and lifestyle modification. Right. And then the other 156 will go to pharmacotherapy and 21 will go to revisionist surgery, correct?
That's right. Of course, there are some crossover from pharmacotherapy to revision surgery, as I mentioned, but the number is like 6-7 patients.
Six, yeah, correct. Because
so,
the flow chart was the drawing down from the lifestyle and behavior therapy.
Yeah,
so
I mean,
ultimately,
I think most patients are still will go for lifestyle and the behavior therapy, seeing psychologists to deal with their eating problems and maladaptive eating behavior, etc. And then the second largest group will be for pharmacotherapy, and exactly that what of the most of the attendees have agreed that would be the first line of the treatment after they fail the behavior therapy, and then ultimately the conversion surgery is the smallest group.
Sure, I think it will be great, interesting to know about because the 599 patients out of 1,500, so almost 30% has weight regain or insufficient weight loss. Am I correct? In the population.
I think that is actually. Yeah, our program is a little bit different from what you see in the United States or in Europe, because we only started bariatric surgery in 2008. So at the time, sleeve gastrectomy is the most popular bariatric procedure. So even if you look at my disclosure slide, almost like 80% of the surgery that I perform is actually a sleeve. And also, I think that the number for revision surgery or conversion surgery in our cohort patients, again, is because we are a young program. I think if you have, like, for example, in US, that's what the data has shown, that ASMBS, they've been doing bariatric surgery for the last 60, 70 years, so that they tend to see a lot more patients who have weight regain. And then, of course, it will follow by more revisionist surgery. But I think the trend is going to be, just like United States, the revision surgery is going to increase.
Sure. Thanks, Chiang. So it will be interesting to see for those with the bariatric, whether anything happening to switch over again over the longer period over the follow up. Yeah. Okay, we got a question from the Dr. Deborah Earn. I think Deborah also from KTPH, I think. In the course of your study, were there some predictive factors that help to predict patients who do better with revision surgery more than the pharmacotherapy and vice versa?
Well, we look at, actually, I think the insufficient weight loss or weight regain itself is different, respond to revision surgery. You're right when we look at different predictors, but the predictor is actually, I wouldn't say it's very extensive kind of predictors. We're looking at patient gender, ethnicity. There's no difference. But the only statistic significant when we do the statistic analysis, the two group itself. Patients who have insufficient weight loss tend to respond better with revision surgery compared to the weight regain.
Thanks, Chiang. So just to follow up before waiting for the other questions from the other participants. So like you mentioned, right, 80% will become a sleeve, right? And then when I think in your study, almost 50 over patients, right? 50%, 50 over percentage will convert from the sleeve to bypass, correct?
Yeah.
Yeah, correct. So then we see the definitive kind of the weight insufficient weight loss, right? I mean the corrective procedure, or being able to achieve the goal, right? Target goal over the 12 to 18 months after the conversion to sleep bypass. Am I correct?
Well, I think the biggest group, actually not the sleeve. I think the biggest group for our cohort patients who have revision is actually lap band. Although I don't do lap band personally myself, but I mean, you would know that there's some senior surgeons, they perform a lot of lap band in Singapore. I think 2003, and so those lap band actually are the highest group that have weight regain, and these are the group that convert. Again, I think there is patient preference and sometimes surgeon preference. Some will go for sleeve, and some will go for Roux-en-Y gastric bypass. I think to discuss which one is better, I think it's going to be another but then the second group is actually from sleeve to we did exclude a lot of patients from sleeve to RIGB, because when you convert the patient, most of the time they don't just have weight regain, they also have some component of the reflux, and that's bothering them. And so to make our data a bit cleaner, so we decided just to look at those patients don't have the indication for surgery are purely for weight, not for other things like erosive esophagitis and other reason for conversion. So that's why the number is actually quite small. If you include those other, if you look at my institutions, all the revision surgery actually are more. But as I say, we exclude those corrective surgery or reversal surgery. We just look at the conversion for weight reason.
Weight reason, all right. So your study population is only for conversion for the weight reason, not for the others.
No, for
other reasons to change.
That's right.
To change.
That's right.
Okay, that's fair enough. I think okay. So for the sleeve, so that if it's a primary becomes the bypass for those patients, right? So I'm not sure, it's difficult to conclude, right? Then in that case, maybe for those patients maybe a so-called the choice of procedure might be due to the surgeon preference, patient preference, right, or other factors, right? So that may be. What do you think? If those patients, right, the conversion, because the revision, most of them are to, conversion to bypass, right? And then bypass into the show to be a sustainable, right? The weight loss, after the procedure. So as a primary surgery, as a bypass, then what do you think it might benefit to those patients or not? I just thoughts during your experience.
This probably just I have to be personally, I don't do lengthening procedure. I don't increase the length of the BP leans or ruling. For patients who have a weight regain or insufficient weight loss from Roux-en-Y gastric bypass, most of the time I would say you do see some pouch dilatations and you do see some stoma dilatations. And this group of patients, then we use endoscopic procedure using an Apollo overstitch. We just stitch up the pouch or narrow down the stoma. But as I say, we don't include that because the mechanism of action of this procedure still remain the same. And we label them as a corrective surgery more than a conversion surgery. But as I say, we do see there's some evidence that converting this group of patients to duodenal switch and those are more powerful malabsorptive procedure have been shown to be quite effective. But also you sacrifice, that you do increase the risk of malnutrition and a different set of problems.
So for your study population, most of the sleeve are the traditional, the normal length, the RAGP, right? Correct.
So for sleeve, usually quite standard. We use a bougie of 40 French, and then for RYGB, we use 100 of a BP and 100 of the ruling. It's quite standardized. For the last 1 year, we start to do more of a revision to OAGB, as I say. Now that Ifso and ASMBS have finally endorsed the one anastomosis gastric bypass. So if the patients have a sleeve, have weight regain, and when you scope them, they don't have erosive esophagitis, they don't have a symptom of a GERD, then we do offer them the options of OAGB because I think technically it's a lot easier, and also they do have a better kind of metabolic result compared to RYGB, at least in our data has shown.
Yeah, that's great. It will be great to have a follow-up studies on this cohort of patients, because you have quite a fair number of the patients who can be followed up to look is interesting, and then also to look into the newer pharmacotherapy.
Definitely.
And then the efficient with the newer therapy, so the patient might be meaningfully helpful for them without the revisions. And then the other one is quite interesting to know that your center is doing the revisional or corrective procedures with the endoscopic treatment, right? So that would be also interesting to see the effectiveness of the endoscopy for the pouch dilatation or stoma size increase inside, right? And then these will be interesting to have a less invasive approach for the patients, for those who fail to or didn't manage to achieve the goal of the weight loss after the primary bariatric surgeries.
Yeah, sometimes it is not easy to convince patients after the weight regain and sufficient weight loss to start on pharmacotherapy, because most of those patients, when they come for primary bariatric surgery, they probably have went through pharmacotherapy and they feel them, right? So then you offer them bariatric surgery. You say this is probably the best options you have, and then you perform the bariatric surgery, and then after that they don't lose as much weight as you want. Then you say, okay, let's go back to pharmacotherapy. Sometimes it's just not so easy to justify to the patients, and so now I usually, when I explain to the patients, I always kind of explain to them, we don't have a very good predictors to tell whether you are better for sleeve or for malabsorptive procedure, and then kind of have a mindset that, what, if let's say this operation fail, then there's always options of doing a different type of procedure. I mean, we shouldn't see a revision surgery as a failure. I think that is very important, because just for example, when the patient have a knee replacement, right? So the orthopedic surgeon will have said, you know what, this prosthesis will last you 15, 20 years. 15, 20 years, you probably require another revision. So when the patient have a revision, they don't see this as a failure. So I think for bariatric surgery, it's the same thing. We shouldn't, limit ourselves saying that, this is going to be one or none. There is always a role for revision surgery.
Yeah, so I mean, there's the process, right? Body process, right? I mean, a lot of things we are still ongoing in the new research, right? We eat
Yes.
after the bariatric microbiome change, a microbiome, and then the flora might change again, and then we adopt it, and then the hormonal changes might happen again, to have a again. So in that case, then technically, how can we address, or pharmacotherapeutically, how can we address? And then for the diet, white rice, they might need to change accordingly because there will be a new kind of the floras inside the body as well, especially if you're interested in the microbiomes. It's a new research will be quite interesting. Okay, why waiting for me discuss? We are discussing there are one, two, three, four more. Okay, you need to address one by one. First is that from Dr. Andrea Furlan. What do you think about the revisionist surgery, sleeve to SADI? Do you think there will be better results?
I think it would. Yes, I think it would, because I think study it tend to. I mean, when you give a patient a sleeve, I understand the sleeve is not a restrictive procedure per se, because they do have some changes in the gut hormone and gastric emptying, etc. But when you want to convert, you convert to something that actually are more powerful, more effective, more adjunctive procedure. I think that always give you a better result, because you already tested the patients with a sleeve and the restrictive, and it doesn't work very well. And then these are the group of patients that I think will perform extremely well if you give them a more kind of adjunctive effect. And if this group of patient, if you do a toninous switch, I can tell you it really will be very, very effective.
Yeah, I totally agree. I think that we need to look at the patient profile, right, and the entire patient as a whole, and see what would be the best so-called revisionist surgery for the patients. Depends on the patient needs and the entire patient metabolic profile, as well as the patient's behavior patterns, right, etc. As the patient as a whole, rather than looking at the technique itself. Okay, next one is from Dr. Yosuke Seki from Japan. After bariatric surgery, some patients complain hunger in the early post-op period, such as the post-op 3 months, and others do not. Do you think this change in the appetite control after bariatric surgery could be regulated genetically?
Well, I don't have a research or something to prove it, but that's my own personal experience. A lot of patients kind of feedback to me after the bariatric surgery, they can't really differentiate thirsty from hunger. And that's actually very interesting. So for my patients who have bariatric surgery after like 3 months or something, they come back to see me, they say, "Doctor, I start to feel hungry." Usually I tell them you try to drink water first. And if you drink water, that sensation disappear, then you actually this hunger. And in fact, actually kind of work for quite, I mean, at least for my patients, they say, "Yeah, Dr. Lim, you're right. After I drink it, I don't feel hungry." So I think that's one thing to do. As I say, we don't study the gatherings and these group patients versus those who don't have hunger. But I think it's something interesting to study as well. But as I say, it's for my clinical experience.
Yeah, I totally agree. I think that there's something, I think also the mind-body regulation as well, right? Sometimes the biological clock might be set somewhere which we don't understand yet. Maybe one is like Dr. Seki say, maybe genetically, right? Something is also the brain somewhere is the regulating, right? Okay, I need to eat. I'm hungry, right? So the mind is so powerful, right? So now we are looking at the mental health issues, right? The anxiety and stress can even know the. I think recently I read the article on even the stress can how much they develop into the cardiovascular disease and then even the cardiovascular related complication and stroke, right? Because of the mind is a powerful. So sometimes, right, the mind and then the brain might have some things to control over that. So that's why you still feel hunger as a usual habit, right? Even though hormone has been corrected, surgery has corrected. Maybe that might be something might need to look into it. In addition to the genetically, as Dr. Yosuke Seki has mentioned. Okay,
Yeah,
next one is
the definition of hunger also, is it craving more than hunger as well? The patient just craving food.
the desire to to eat more, or
Yeah.
that's just the craving, and whether we cannot eat right after the hunger is still there, the appetite is still there, etc. Even now with the COVID also, right, the appetite is lost for some reason, right? The, the virus has changed the body, or the taste and then the smell. Okay, next one is Prof. Jack's impens. Maybe I missed it, but in methods, what were the criteria to choose the revision versus drugs? Okay, that's for your in the study. What are the methods to criteria to choose revision versus drugs?
It's a very, very good question, Prof. Ibens. We don't really, it's not a randomized study or anything. So most of the time, it actually depends on the patients and the physicians, the surgeons. We discuss, and then and we give them the options. But you're right. I think that we're still leaning more on starting the pharmacotherapy first. As I say, because pharmacotherapy have carry a lower risk. But as I say, even with the, I mean, let's say the patients have some side effect with the amphetamines, and you offer them the next option, liraglutide. Sometimes cost could be the issue as well, because the liraglutide is actually quite expensive in Singapore. So some patient will just say, you know what, just go for the surgery and see how.
I think with the newer drugs, that I even see the pre-op patients, weight loss is fantastic. I mean, one of my patients before I do surgeries, they managed to lose weight for 30 kilos with the semaglutide. Yeah.
Yeah.
Okay.
I have no question.
Okay.
These new drugs are actually very effective, but I think it will be interesting to see whether they have a similar kind of effect in longer term, whether they
Yeah, I
will
think whether it's only the pharmacotherapy will be good enough, or pharmacotherapy as a bridging therapy right before the surgery. So a lot of things we need to look forward through the future research and studies. Okay, next one by Dr. S.K. Sharma. Do you see any role in future for endoscopic procedures like duodenal resurfacing before revisionist surgery in patients with insufficient response to sleeve bend?
Well, I think if you look at the duodenal resurfacing, just take that for example, it actually shows some benefit in terms of the diabetes control, but when it comes to weight loss, it's actually terrible. They have very, very minimum weight loss. So I still don't think that they'll be effective to the extent where they can replace the revision surgery. Of course, I think certain endoscopic procedure is useful. For example, if the patient have a sleeve and then they have a pouch, they have a sleeve dilatations, and the patient is not keen to go for another re-sleeve or revise it to a RYGB or OAGB, then you actually can consider using an Apollo overstitch to narrow down the sleeve itself. I think that the role is there. Is something you can consider. Yeah.
Yeah, definitely. Yeah, I think so, because of the more and more MIS, right, and minimally invasive to the organ preservations. So it will be the something as a bridging to see as a stage procedure, rather than straight way to the more fundamental. That will be something interesting, because patient also might like it, and these are the options can be offered to the patients with the newer, evolving the endoscopic treatments.
Yeah,
Okay.
I think weight management probably are leaning towards a little bit like cancer management, like breast cancer. You don't just offer them surgery, or you don't offer them just RT or chemo. It is a combination tend to give the patient the best result. The patient will go for RT first or chemo first, downsize it, and then you excise it. I think for weight management also, I think that's why I think it's important for a program to have all the skill set and all the support that you can offer different combinations of therapy for patient. I think that that will be the future of weight management.
Definitely. I think it's more and more for the different the combination, right? Because from the beginning, the bariatric, weight loss management is the weight management is the multi-D, right? So as per multi-D, it will become a really multi-D with the different, even the different specialists and different the techniques. Okay, the last one in the Q&A is the Prof. Butterham found that that's from the Prof. Jack's impens. The Prof. Betterham found that weight loss after 3 months predicts the final outcome, and poor weight loss at 3 months should encourage the use of the semaglutide at this early stage. What is your opinion?
Yeah, I agree that his study has shown that there is some benefit. But if you look at the study, that the weight loss is actually not as good as the primary users semaglutide as a primary treatments for patients who have obesity. There's some reductions in terms of the effect. So as I say, you know what, when patients have weight regain and they're not ready for revision surgery, the pharmacotherapy is always options, and whether you're using the old drugs or the new drugs, and I think I mean, if you have the semaglutide available, if the patient can afford, and I think there's always the road to try it.
I think also it's important to look into what is the correct based on the patient's profile, metabolic profile, and what will be the most appropriate, based on patient-centered care, right? Patient-centered appropriate so-called the anatomical alterations that as a primary preventive procedure, so it plays an important role, I think.
Yeah, that absolutely right. I think that if you have a procedure that will engage the GLP-1 kind of and the effect, so then I think using semaglutide probably have less effect compared to someone just have a, let's say, lap band, is pure restrictive, and then you add a semaglutide. I think they probably will have a better result.
Yeah, I think in the end, it's like I mentioned earlier, we discussed earlier, it will be a multi-D, and look at the patient as a whole, the entire metabolic profile, a lot of informations, including the behavior, psychological, right, and then even the mental issues to be addressed, everything, and then see what will be the appropriate choice of the surgery or combination of the surgery with the pharmacotherapy and then behavior therapy, all these things to be together to achieve the better outcome for the patient, I think. Yeah. I think now it's almost 3 minutes left. Any other questions? I will open for the last Q&A question from the participants. If no questions, then probably we can close the today webinar. Okay, I will wait for a few seconds. So any more, Stephanie? Any more last? Okay, Stephanie replied no questions. That's good. So I think with this, I would like to thank all the participants for the very good Q&A, and thanks Ching Hong for the very good study, and as well as the very good presentations and wonderful discussions we achieved today. And then I'm looking forward to your centers, right? More and more papers on this study populations on the different aspect of the follow-up. Looking forward to it. And then I would like to, thank you, Chiang. Thanks a lot for your wonderful presentation and time. And then thanks all the participants. And then just a final few reminders that this webinar will be recorded, and then it will be available on the Ifso YouTube channel, as well as the Ifso the website, the academia. And then also with this, I would like to invite all of you to join the future Ifso webinars. It will be available and announced by the Ifso in the Ifso different form of the social medias, including the Facebook, Twitter, right? You can follow up the Ifso Twitter and Ifso Facebook to look out for the announcement by, I think Manuela will announce every future webinars. Please join us, and then wish you all a very good day, and please take care and stay safe. Bye-bye.
Bye-bye. Thank you.